Now we would like to move ahead to the next session. Kawasaki disease is a leading cause of acquired heart diseases in children, and understanding its clinical presentation and treatment strategies is crucial for improving outcomes. I am delighted to announce our next speaker, Dr. Vijay Viswanathan, Senior Consultant, Pediatric Rheumatology and Chairperson of Pediatric Rheumatology Society, who will share his valuable insights on the diagnostic and therapeutic challenges involved in Kawasaki disease in infants. Thank you, sir.
Very good morning to all of you. Mine is going to be a very, very clinical talk, unlike the previous exhaustive scientific talks. And we've had a lot of Dada 1 and Dada 2 in the morning, so I thought it would be just apt to start with when all of us were enjoying Dada 1, actually, who was at the helm of affairs of BCCI and Indian cricket. And those were the good days when the pediatrician used to think that once you diagnose KD, give IVIG, job's done. And this was a kid who incidentally came to me in 2014 at 4 weeks of illness, and the reason she came to me was this was an adopted kid, and this girl was given IVIG alone at 2 weeks of illness and referred to me at 4 weeks saying, "एक बार देख लेना कुछ हो रहा है क्या उसके साथ," because we are slightly concerned about the other parts of the family. And when I saw this girl at 4 weeks, her CRP was 30. She was not having fever. She looked reasonably comfortable, but what made me a bit uneasy was the right coronary Z scores were slightly on the higher side. I said, for want of anything, just give steroids and a low dose aspirin and please come back and repeat a 2D echo at least after a month. They listened to part of my advice and they came back, but after 3 months, they did not take the steroids. The low dose aspirin was not started, and at 3 months, this single RCA dilatation was showing 2 aneurysms in the same coronaries, and then you start looking at the ugly face of Kawasaki disease. It's not always hunky-dory, and we know that in children who have a missed diagnosis or a delayed diagnosis, we get into trouble. And these kind of problems are more exaggerated in the infantile age group, as we all know. So my topic is going to be a bit of an overlap of incomplete as well as infantile, because I think they go hand in hand. And like I said, in the early days, you have 5 and you have fulfill 4 out of the 5. You know that this is typical Kawasaki disease, which begs the question, is IVIG enough? What's the scope of intensification? But over time, 1 or 2 of those members started disappearing, and you started looking at really incomplete ones. And this is the situation which Mahesh also adhered to in the previous talk. When do you start thinking of the other ones? And last but not the least, we are suddenly seeing a lot of extended presentations or atypical Kawasaki disease where it's obviously the story is to throw the potential kitchen sink to save the life. While Dr. Kawasaki was diagnosing KD in the 60s, we were happily singing to this song, which I think reflects KD to the best. You know, it has always been an enigma, and I think Mahesh has promised to sing this song in the evening banquet. And to sum up KD in one slide, I think we know that there are quite a few known things. There are a lot of known unknowns, there are unknown unknowns, and a lot more unknown unknowns, like Mahesh showed in his last slide. I'm sorry to get the weather map. Dana is certainly out. But in the olden days where I had seen a bit of outbreak of KD in where I practice, I was just Googling up why am I seeing so many KDs. And one of the earliest theories was staying closer to the water bodies, heavy industrialization, and mangroves was supposedly one of the proposed hypotheses initially. And there's a strange and uncanny resemblance between Japan and Navi Mumbai where I practice, and which I think probably may not be definitive, but certainly has something to contribute. And go to the east coast, and I think Odisha is pretty similar to Navi Mumbai, where we almost got a cyclone, but I won't be surprised if Debashish ends up seeing a lot more of these presentations, right? So coming to the cases quickly, this used to be the profile of the kids I used to see. This was a 11-month-old fever shock infant with 25,000 counts, high markers, And this child used to come with fever for a day, 4:30 comes to the OPD with fever, 6 o'clock refusal to feed, and then ends up in shock at 8:30. And when I got to see this child had a BCG reactivation, a very high N-terminal pro-BNP, a low ejection fraction, a high ferritin, and this kid actually ended up having a bowel wall gangrene, needing a resection anastomosis, and the whole spectrum of medicines, and I'm talking of 2017-18. And many of these kids used to present with significant shock and features suggestive of Kawasaki disease. And I almost used to started using the phrase Konkan coastal shock syndrome instead of Kawasaki disease shock syndrome, because I had never seen such an outbreak. And 2 years later, something similar happened. Kid with Kawasaki with GI and CNS, we started calling it as MISC. So makes it more interesting. This is for the pediatric audience. Incomplete disease, atypical disease, are they the same? We'll probably, for understanding purpose, call incomplete as fever with less than 4 out of the 5 clinical features with compatible lab and echo findings. And atypical is when you present with atypical features like renal failure, kidney injury, etc. What makes incomplete or infantile KD more interesting is the spectrum of unusual or different presentations like shock, as we saw, pneumonia, lymphadenopathies, nephritis, aseptic meningitis, gangrenes, cranial nerve palsies, etc. And obviously all the pediatricians are more interested in seeing infections, and they look at infections, and the problem is if you have a proven infections in the setting, then it becomes more complicated to diagnose the KDs in time. The other issues with incomplete Kawasaki disease, obviously we don't rely on the criteria for diagnosing. This is again for the pediatrician. Think that even if you have an infection, you may still be dealing with an inflammatory complication. Remember that all the features of KD need not be present. It may sequentially evolve or it may be disappeared when you are seeing the kid. The reluctance on the part of the pediatrician to think of KD and the parents is often a problem, I feel. And obviously, even if you diagnose, there is still a lot of lack of evidence to manage these kids. Throw in atypicality of presentations. We still don't think the IVIG markers that the Japanese follow, we may not be able to quantify exactly vis-a-vis our population. When do I intensify the treatment options? Everything seems to be a bit of a issue to manage these kids. For the pediatrician, remember the first week of Kawasaki disease always invariably has myocarditis, which is more because of interstitial edema, and NT-proBNP is often a marker which gets you out of trouble. Coronary artery lesions at diagnosis seems to be a very, very high risk for long-term morbidity, and we are seeing a lot more atypical presentations. This was a kid who I saw on day 364, and I'm saying that for a reason, because the first birthday, this child breaks into an urticarial rash, and the pediatrician by default gives hydrocortisone, and then this child is extremely irritable. Take-home message is, when you see a child who's febrile and urticarial within 1 year, please have a look at least the BCG. The BCGs were reactivating. Don't forget to see the joints, because IV going out will not cause edema of the fingers, right? And this child indeed turned out to be having severe myocarditis with aseptic meningitis. And when you give IVIG to this kid, this is the classical irritability that I want all the pediatricians in the audience to have a look. And then what happens 3 days later into the story, this is the same kid who goes home on his first birthday, gets celebrated in the hospital, but within 3 days, he's going home happily and he gets a complimentary bill from the hospital, but his life is saved, right? So this is the importance of picking these kids up earlier. This is actually Dr. Suma's case, and we had used it for our training module. And this, anytime you see a febrile infant less than 1 year with a facial palsy, please think that you need to be very aggressive in ruling out KD, screening for coronary morbidities, because these are kids who need very, very upfront aggressive therapy. And I've seen 3 kids in the last 6 months with similar presentation. This was a kid, another unusual presentation, who had torticollis, And remember, when you start seeing torticollis with a quinsy-like presentation, and you get a call that this child is not getting better, please do a CT scan, and sure enough, you will see a retropharyngeal collection. Remember, the retropharyngeal space has loose connective tissue, and a little bit of edema can obviously skew the diagnosis or push you in favor of Kawasaki disease. The thing in fashion in Maharashtra is mycoplasma these days, and this was a child who was diagnosed as mycoplasma pneumonia, and fever kept on persisting, became azithro-resistant mycoplasma, and then the tongue started becoming red and the rash appeared. So remember, even in the setting of proven pneumonias, there are enough articles to say you may be dealing with a post-inflammatory inflammation like KD. Don't forget the BCG, especially in the infantile and the younger age group, arthritis, and any infant with anasarca, with a high ESR, with fever, think you may be dealing with KD. Last but not the least, this is my youngest kid who came to me on day 26 with fever since day 15 of life. This was in 2016, and this neonate had a gangrene or something which looked like a medium vessel vasculitis, and we treated him like Kawasaki disease. Now, this child, in those days, we were not aware of the DADA2 mutation, but this child had a lot of coronary dilatation and responded very well, and at 6 months, the echo was normal. This kid I saw last week, saw on day 14 of illness, 9-month-old, had everything to suggest KD, but the pediatrician diagnosed measles. And when I saw this kid, he already had a huge dilated coronaries. LAD was 9, RCA of 7, LMCA was high. And this is a typical situation where you would wonder why, and I was asked, why are you using everything? Why not only IVIG? I said, one more clue for the pediatrician if you're in a doubt, if it's measles or Kawasaki, have a look at the dress the kid is wearing. This child was wearing a diagnosis written on his t-shirt or the scrubs with an atypical color. And I ended up giving IVIG and infliximab, and believe it or not, at 2 weeks, the 2 coronaries had become normal and LAD was 5. And the inspiration for doing this was obviously from this single center observational study by Jane Burns' group, which was published in Archives in 23, where they compared they talked about infliximab intensification in someone who already has a coronary artery lesion at diagnosis. And they found that IVIG alone works slightly inferior than IVIG plus infliximab at 5 mg per kg, works slightly inferior, and the best combination was IVIG with 10 mg per kg infliximab at the onset, especially in a child who has such florid coronary artery lesions at presentation. This would lead to a larger chances of coronary artery regression. Where does it leave infliximab then in the schema of management? I think the way to understand is, we know from the KidCare trial that infliximab works as good as IVIG in reducing the markers, activity, but we don't know what happens to long-term coronary outcomes. But what we certainly think we know is, it's definitely good in the other things, but if you are encountering a coronary artery lesion at the onset, you may have a role in intensifying upfront with the 10 mg per kg in addition to IVIG. I won't talk about the cyclosporin KAIKA trial for want of time. This is one last kid who I probably hope that none of us see, but we may start seeing these kind of kids. This was a 1-year-old male child, and remember the date was 26/11. I don't need to remind you what happened in 26 of 11. It's an inflammatory day in Mumbai. This kid was exactly, again, first birthday, presented with high-grade fever, cold, urticarial rash, and decreased oral intake, like any septic child. And this child had a rash like this, had mucositis, conjunctivitis, left cervical adenopathy. Everything seems to be very straightforward and looked like KD. But then the thing was, the pediatrician has to be sensitized to the point of thinking KD. But it goes to the usual septic workup. Everything was seemingly normal, looking like a viral. CRP 64, ESR was 60, cultures were negative. The biofires grew not 1 but 2 viruses, and the child was started an antibiotic. On day 5, this child actually started having shock-like manifestations, and then the febrile illness with a rapid progression to shock, which is when they got the rheumatology into the picture. And while they sent the extended septic workup, the working diagnosis was KD shock versus septic shock, infection versus inflammatory workup was done. And this was the first and the subsequent blood work where the counts had started climbing up now. Platelets were still on the lower side, CRP, ESRs were climbing up, albumin was dropping, and the NT-proBNP was 1,000 odd. This was the time we get the 2D echo done, roughly around day 7 of illness, and this showed a dilated left atrium, left ventricle with ejection fraction that was low. Z scores were seemingly okay at this point of time. But then I said, let's go ahead and give IVIG for want of anything, because we are looking at a clinical diagnosis of Kawasaki, and the other things would probably come negative over time. Now, post IVIG 36 hours, the child continues to run fever, and obviously because of the lymph nodes, the USG was done, which said lot of non-necrotic nodes. The parents refused a CT scan for radiation fears, and then we continued the search further. Why is he resistant? And sure enough, the CRP was climbing up post IVIG from 150 to 200, and this child was still in trouble. And we got a repeat 2D echo done in 3 days' time, and this started showing dilated coronaries. The LMCA, LAD, and RCA had started becoming significantly dilated. And that's the time when we started thinking, what do we do? I went back to the old tested solumedrol, methylprednisolone, but then methylprednisolone also, the CRP kept on climbing to 238. Now what? And then the coronaries were progressively increasing. Now, after 3 doses of methylprednisolone, the 2D echo was very scary. It started showing me giant aneurysms in 2 main coronary vessels. And then what do I do? What would people do? I gave infliximab based on the previous theory, and that was around day 15 to day 16. And post infliximab, the fever reduced. However, the ESR came down from 250 to 47. But then the fever was still there, that 9900 fever was still happening. Then I said, Kai ka risk lene ka is a very, very Marathi term. And I put this child on cyclosporin, because that was the next thing available while we started mobilizing. But I was just going with the sequential part of it, and we don't know what's the best thing to do when you're encountered with an incompletely IVIG resistant KD. You have all the menu card in front of you, but picking and choosing amongst this, in Odisha, Debashish will have this kind of a problem, Someone would want to go conventional IVIG with steroids. That's the first combo. Throw in a bit of oral steroids, cyclosporin. This Kisede sounds very much like Kaika, cyclosporin. Throw in IVIG plus infliximab. The Odisha people are extremely clever. The spiciness of aloo is cooled by the coolness of dahi vada, apparently. And end of the day, you leave it to Lord Jagannath to help us out, with the Kaja Prasad, save my life, right? So, last 3 slides, I think Priyankar is still there. He remembers this photograph in Bangalore conference where I had to use my Naga warrior skills along with Cochrane to convince that at least in certain situations in KD, we can use steroids. Like IVIG resistant, initially Kobayashi scores were more than 5. Features of HLH, definitely steroids have a role. High risk KDs, this used to be our go-to weapon till now. The point I'm going to leave this audience with is, when do I start using anakinra or think of anakinra, assuming that should it predate the infliximab, should it come after infliximab, should you wait for an anaconda to develop inside, etc. And then we have a few upcoming studies which give us a clue. So the ANAKID trial says you give anakinra IV, helps in having sustained levels of anakinra in the blood. It has a shorter half-life, gets in, gets out quickly, so a lot of safety margins. And we are seeing more and more case reports where high-dose anakinra has been used for treating infantile and neonatal KDs. The best article I have read is from this, where it summarizes about 38 kids. It's a case series of 38 kids, including the Kawasaki 16 kids group, where on an average, anakinra starts getting introduced by day 15, and there is no limit because each one of them have followed their own schedule, with the lowest being 7 days, maximum being 87 days. But definite evidence that it works as good as infliximab in getting out this toxicity, clinical features, fever, better recovery clinically. And there are a few studies which says that if you throw it in early, you may end up seeing a reasonable coronary artery result. And especially in my situation, where the commonest indication for using anakinra in all of them were KD shock syndrome and HLH, which I think is a no-brainer. We have been using anakinra in many kids with HLH. Worsening coronary aneurysms have been reported in 2 or 3 of them, but the regimes have been varied. I think the conclusion that I took from these studies was it can be used if at least 2 treatments have failed. In cases of coronary artery aneurysms which are worsening with time, despite the child seemingly getting better. And what's the harm is the financial aspect in our country. But I just read that it's probably cheaper to give anakinra than an IVIG in certain European countries. So what do I do? This is the second last slide, I promise. What's my way? So what I do is, it's just a straightforward infantile KD, no high risk, no coronary artery lesions. I use plain IVIG, stick to convention. If it's an infantile KD with a high risk, low liver functions, low albumin, HLH, KDSS, I generally start by using IVIG and steroids. Infantile KD with high risk, with a coronary arteries more than 5, I start getting worried. Definitely, I throw in infliximab at a higher dose. Infantile KD with a giant aneurysm at diagnosis, I think you will probably consider anakinra. And if you have facing a course like how my kid, I may definitely use anakinra. The next time probably a bit upfront. This is normally how pediatric rheumatologists are. We are very happy, smiling, peace-loving human beings. And I often discuss with Suma and Priyankar, why do I see only, barking dogs seldom bite, as I call. They come, they scare, they come in shock, but you get him out of trouble. They don't have long-term coronary bad things, like how the East and the South has a look at it. So while genetics we can't debate, the probable logical thing that Suma told me was, maybe you see more kids with shock, maybe they come to you earlier, maybe you hit hard earlier, possible. So which is where the important message is, intensifying in the correct situation becomes important. But when I see Suma's messages on the group, IRA for 2 weeks pay Z score is 9, Z score is 10, what do I do? Not 1, not 2, but 10 kids was what she saw in the month of September. I said, either you give me a job or send them across to Bombay, they'll get better. And I'm sure Priyankar sees similar kind of, and this is the change of emoji that happens. And this happened 2nd October, 1 month after the epidemic. Suma started looking like this, and Priyankar had already given up on many of the pediatricians. But then again, I think there is a definite environmental and a genetic story happening as to why the eastern part and the southern part see bad vasculitis beyond early referral to me. I'll finish with this. I think अजीब दास्तां है ये, कहाँ शुरू कहाँ ख़त्म, ये मंजिलें हैं कौन सी, ना वो समझ सके ना हम. For Dirk, I'll tell you the meaning in the evening gala banquet. Right? So straightforward Kawasaki disease, there is no problem. It obviously reveals itself a lot. The incomplete KDs are the ones which I think you should probably be slightly careful, because you will have to read in between the lines. And last but not, and definitely there is a role to call a friend. But then the atypical ones are the most scary, because you will really need to have a low threshold and a high index of suspicion before you connect the dots. And please, please, please phone a friend. I thank you for this opportunity, and open to questions if there are any. Thank you very much.